Great. Thanks so much, Prof. And I also want to thank the School of Global Health for the invitation to participate in today's webinar, and also for us to be able to share the work that we do as an organization in advancing rural health equity in South Africa. In keeping with Dr. Michelle McIsaac's presentation on the guidelines, or the WHO guidelines on workforce development, attraction, and rural recruitment and retention, I thought it would be wise to identify one particular recommendation that South Africa actually implemented way back in 2004. So yes, the South African government implemented the Rural Allowance to attract and retain health professionals to rural, underserved, and inhospitable areas. A study was then conducted in 2011, looking specifically into how the Rural Allowance was implemented in hospitals in the Northwest Province. What the findings revealed was that there was partial effectiveness, or that we were actually unsure as to whether this was an effective policy intervention or not. There was inconsistency with the way the policy was implemented. Not all health professionals received rural allowances. So, for example, junior nurses, for example, did not qualify for rural allowances. And this then led to divisiveness and staff dissatisfaction. What the study also revealed was the effects of rural allowance were actually short-lived, and that financial incentives alone are not enough. I was happy to hear that Dr. McIsaac mentioned or spoke about a bundle of incentives. But the reason in particular why I chose this particular case study was to kind of put the question out there about how do we go about actually developing policies, and do we actually always consider the unintended consequences of the policies that we do develop? To bring it back home to South Africa, just a brief overview of rural health in SA. Of a population of 59.3 million people, approximately 38 to 42% live in rural areas. What we call the homelands, which I think in other countries are referred to as reservations, were systematically underfunded. And just to give an example, in the years 1986 and 1987, the health spending in the homelands was less than 3 times that of any other person in the rest of the country. If we fast forward to the present, we are well aware of our persistent economic recession, as well as the austerity measures that have been applied, which obviously affect funding for health, education, and social services as well. In terms of health funding, we are also aware that this is based on population and not necessarily need. And so this does not take into consideration some of the historical challenges in terms of infrastructure, and I would say underdevelopment of health systems in predominantly rural provinces. We are very much aware that rural provinces have a much lower density of skilled health professionals. And in terms of our rural health outcomes, what we do know is that the majority of the 10 worst performing districts in maternal and child health are actually in rural. In terms of some of the threats and challenges we've identified to rural health, the one is the actual nursing crisis. To elaborate, this refers to the demographic transition taking place within nursing. So it is expected that by 2013, our nursing workforce will be halved. And this is due to a number of different reasons, including retiring nurses, immigration, as well as a slow accreditation of nursing programs, which results in the delays of admitting students into nursing programs. The pie chart reflected on the right of the screen shows that in the region colored red, that's 27% of all nurses are between the ages of 50 and 59. And then on the extreme left in the darker blue, we can see that 26% of our nurses are between the ages of 40 to 49. Only a marginal percent of 6% are actually under the age of 30. In addition to the nursing crisis, we are aware of, as mentioned previously by Theodora, in terms of health outcomes in rural areas and how often globally they tend to lag behind that of urban areas. These two charts reflect the performance of maternal mortality in facility ratio on the left, as well as neonatal death in facility ratio on the right. And this actually reveals that, again, if we look at the bottom of both images, we see that the lowest performing districts are actually predominantly rural. And so our question as an organization was, can the community service nursing program become more responsive in addressing rural health systems challenges? The first one being the demographic transition in nursing, and the second one being the poor health outcomes in rural districts, and how the strategic deployment of ComServe nurses could actually bolster health systems with poor health outcomes. We are trying to adopt a systems thinking approach to the work that we are doing. And I think it's important to first acknowledge what exactly is a system. So a system is a group of interacting, interrelated or interdependent parts that form a complex or unified whole that has a specific purpose. I thought I would be a bit cheeky by asking this question, but based on the description given on the screen, is your multidisciplinary team actually a system or not? What actually is systems thinking? It's basically about understanding how systems work, and that problems that we see are part of a broader dynamic system, and it actually helps us to design interventions that are a better fit for purpose. Systems thinking is great for what we call wicked problems. And many of you may be familiar, obviously those working within the public health space, with wicked problems. We might just not have the terminology to call it that. But wicked problems are basically problems where it isn't a very straightforward A leads to B solution. We find that there's multiple interconnected and interdependent elements. There might be multiple stakeholders with varying values, experiences, and worldviews. It might be a problem that is extremely resistant to change. So even though there were previous attempts to change this program or system, these have either been unsuccessful or have had very limited success. Because there's these different values, experiences, and worldviews, it means that not all of the elements within the system actually understand the problem in the same way. As such, there's no universally agreed upon explanation because people perceive it or experience it differently. Because there actually is no consensus on, what exactly the problem is or how it is understood, this means that there actually is no universally agreed upon solutions and therefore no universal template that we can use to address these problems. So again, I'm sure many of you are experiencing wicked problems or are in the process of trying to, I would say, quote unquote, fix wicked problems. This is the approach we took to understand how best we can look at the community service program, specifically for nurses, to see how best they could be responsive to rural health systems challenge. Part of this process that's identified on the screen is actually adopted from the systems thinking guideline for health system strengthening by the World Health Organization. What it first tells us is that we actually have to ground ourselves in the data. This meant that my colleagues and myself had to pretty much review all of the literature available around rural health, specifically around, workforce maldistribution, looking at the challenges within nursing, and then also looking at the community service program as well. What we also then had to do, which is extremely important in systems thinking, is to actually test our assumptions. We did this internally within our team, within the Rural Health Advocacy Project. But then we also tested our assumptions by individually consulting with a whole host of different stakeholders, ranging from the National Department of Health to Provincial Department of Health. We spoke to academics, we spoke to unions, actual young nurses who were undertaking the community service or had recently completed the community service. And we then had to go on to convene individuals as a collective. So first we engaged with individuals one-on-one, and then this moved on to engaging with these individuals within a convening. We hosted a series of convenings. The first one basically looked at what does the current system look like? The second convening looked at what is the ideal system that you can envision. And the third convening looked at how do we actually get to this ideal vision or ideal system. Again, in systems thinking, it's extremely important to be able to develop a common understanding of the problem and to also be able to develop a shared vision of how to actually solve this problem. Through these convenings, we collectively identified leverage points. And essentially, leverage points are basically just, I would say, tweaks within a system that can create some sort of change. This is an ongoing process. And currently where we are is we've consolidated these leverage points, and we are now about to share them with all of the stakeholders to be able to reflect on and to critique as well. Thereafter, we will then be meeting with these stakeholders individually to mutually discuss how plans can be realized. Some of our findings revealed the following. So many of the leverage points that were identified from the convenings mirrored those of the WHO guideline on health workforce development, attraction, recruitment, and retention in rural and remote areas, as well as the 2030 Human Resources for Health strategy for South Africa. Some of the leverage points identified to improve rural recruitment and retention also mirrored those that could potentially address the demographic transition within nursing. We found that in the consultations that we hosted, both the individual consultations and the collective convenings, there was a focus on the persistent issues within nursing. And therefore, this demands that these issues actually be addressed. What we also found was that, districts play an important role in determining where ComServe nurses are actually allocated, and that we would have to actively engage with them. In terms of just our internal sense-making process and the way in which we actually try to identify leverage points and then determine who actually would be able to take on these leverage points is reflected on the screen in front of you. So again, we consolidated all of the leverage points that came out of the individual consultations as well as the convenings. And then we reflected this against the best practice that was available, or WHO guidelines, for example. And we went through this process of asking what was the system value of a particular leverage point? What was the supporting evidence for that? What exactly do we want to achieve? Who should lead on this? And a lot of this was, in terms of who should lead on this, was identified through the convenings, where we were able to identify that certain stakeholders had a particular interest in a certain area. Who is the final decision maker? What are the unintended consequences of this leverage point? We then tried to go on to rank the difficulty of it. And then we had to figure out, well, is this something that our organization should be taking on, or is it something that another stakeholder should be taking on? And so we had to ask ourselves, how does it align to our organization in terms of our resources and capacity, our positionality, as well as our vision and mission? This slide does not represent all of the leverage points, but I've basically used it as an example to show the sense-making process that we went through. As I've said previously, we identified a whole host of leverage points, and we then had to go on to identify, well, who then is responsible for this particular leverage point? And these are listed on the screen. So in terms of the National Department of Health, we identified a possible advocacy tactic was the ring fencing of community service posts. An actual rural-proof community service policy, which should include all of those listed on the screen. And the reason why we've wanted all of that to be covered within the policy was because, one, it was based on previous evidence, specifically South African evidence, as well as these were very important points that were raised in the individual convenings, as well as the collective convenings. We also had identified advocacy points for the rural provincial departments of health, so the introduction of a pro-rural orientation and induction program, mentoring, as well as learning platforms for nurses. We also identified certain leverage points that the regulatory body could take on, as well as academia as well. Just to reference back to what Dr. Michelle McIsaac spoke about in terms of a bundle of recommendations, we're very much aware that, you know, rural recruitment and retention is not dependent on one recommendation. And so if we look back towards the beginning of my presentation, where we looked at the rural health allowance and whether it was actually effective or not, we see that it takes actually a bundle of recommendations to be able to achieve rural recruitment retention. Back to our original question, which was, you know, can the nursing community service program become more responsive? Does it have the potential to alleviate the impending shortage of nurses? We said yes. Community service officers, for example, could be retained post-ComServe, and we have identified provinces, specifically the Eastern Cape, that actually have gone on to retain ComServes post their ComServe year. However, and this is a very strong however, this must still include supporting factors like positive practice environment, mentoring, supervision, and accommodation. Can nurses be allocated based on need? We are aware that the provincial departments are responsible for identifying facilities, but as this is an ongoing process, we need to engage further with districts to better understand how exactly they do their placements. And I'm just about to round up now, Prof. The final remarks are, you know, the report that we have put together based on the convenings and the consultations, as well as the leverage points, that's not the actual end goal in all of this. It's actually the relationships and the connections between the stakeholders, more especially the development of the horizontal relationships across the different levels of health governance and other sectors as well. Yeah, the importance on focusing on the process rather than the outcome, to allow for sense making to take place, to check biases and assumptions, and more importantly, to develop a shared understanding of the problem to work towards a shared vision. We found that the systems convenings that we held allowed for a reduction of hierarchy, which means that different levels of health governance were able to engage with each other on an equal platform. It also allows for movement building across sectors. It harnesses local capacity. Again, we should always consider what the unintended consequences are. Our next steps are to share our consolidated findings with stakeholders and to reconvene with stakeholders individually to discuss how plans can be realized. And lastly, this is an ongoing journey. Thank you.